It does.
Welcome. Hey,
Hey.
on behalf of the Association for Vascular Access and the I Save That webinar series, I'd like to welcome you to today's presentation, Understanding the Role of Ultrasound Gel in Ultrasound-Guided Vascular Access, the Good, the Bad, and the Ugly. Join with me in the virtual studio today, as always, Judy Thompson, and our presenter tonight, Dr. Nancy Moreau. Hey, Judy.
Be a great show. Yay.
It's a pleasure to be here with you all today. These are my disclosures. I do work as a CEO for PIC Excellence and own PIC Excellence, as well as do consulting work with a variety of companies. So our objectives for today, we're going to be talking about current practices with ultrasound-guided venous access and the supplies that are used for those procedures. We're going to evaluate the types of insertion procedures with ultrasound and the evidence that identifies breaks and problems with aseptic technique. And then we're going to talk a bit about gel, packaging options, and methods to reduce concern, what the evidence is, and what the associations say about the use of protection and contamination concerns. So our current status with ultrasound-guided peripheral catheter insertion is that more than 63, 69%, depending on what you read, of patients in the hospital are difficult to access. More and more clinicians are learning, are being trained in the use of ultrasound for needle guidance and peripheral catheter insertions. One report estimated that there were more than 12 million insertions in the United States alone each year with ultrasound-guided peripheral insertions. We also have concerns over central line associated bloodstream infections, and so a need to be more efficient and effective with peripheral catheters, not only to insert them more effectively and successfully, but also to maintain them in a way that is free from complications. We have so many clinicians that are performing ultrasound-guided insertion. There's a lot of variability that we're going to be talking about in the procedures and the supplies that are used. There seems to be difficulty with hospitals and facilities catching up to this new practice in terms of establishing policies and applying the guidelines that are present within the different organizations. We do hope that people get trained to use ultrasound if they're going to be sticking needles in patients. And I think the majority of them are being trained, sometimes on the job training, sometimes a variety of other ways. But we do feel like invasive procedures should have training. And then we have to recognize that there's risk for these patients, especially when we puncture skin. Even though we recognize that ultrasound in and of itself is not invasive, the type of procedure that we're doing does carry risk in a number of ways that we'll be discussing. Not only do we have team usage, but we have a lot of other people who are doing it or who want to be doing ultrasound-guided peripheral access. So the title talks about the good, the bad, and the ugly. I think the good is that there is attention being given to the risk and concerns associated with ultrasound-guided PIV insertion and the wide variety of people and departments that are utilizing this new visualization technology. And I mean, for many of us, it's not new. I personally have been using ultrasound since about 1998, a long time, but for peripheral access and for many people, it is new. The Infusion Nurses Society recent standard practice release did address the issue of vascular visualization and ultrasound use, and basically said that there should be a sterile and single-use gel packet and a sterile sheet that's utilized with the procedure for protection of the probe. And then, of course, probe disinfection before and after the procedure in order to reduce risk, in keeping, of course, with manufacturer recommendations for cleaning and the types of solutions that are used with cleaning. And so the good thing is that more and more organizations are taking this on and are looking to the evidence in order to make decisions. Unfortunately, some of the evidence is pretty sparse. Yeah. So we do recognize that some organizations like ECRI have listed ultrasound-guided PIV as a risk factor. ECRI is specifically saying, that quality and safety in the organization is at risk because of the rapid rise in the use of ultrasound-guided PIV insertions. Because there are so many of these insertions being done, it has outpaced the healthcare ability to keep up with policies and procedures and necessary training that should go along with it. And while people may get initial training, it's questionable if there's any follow-up training or if there's any follow-up monitoring as far as the success of the procedures or the success of each inserter, plus the compliance of the inserters with the policy and the application of the guidelines. And so ECRI is basically saying that they have concerns over the skill of the inserter and their effective use of the technology and appropriate use of safety products and supplies. So each of these are a concern that we have to address, and certainly we want to, look at a number of things in order to determine, what safety practices we need to use. Somebody was asking me about where that 12 million came from. And I can tell you it was in a publication by Dr. Murich, M-I-R-S-C-H, Lewis and Awe in 2018, where they talked about incidence and usage. And they specifically quoted that number came from Gottlieb's study on ultrasound-guided best practices and the narrative review. So we'll keep going forward. The biggest concern that I have and many associations have is on the compromise in the aseptic technique. I think that we're all aware of the risks and concerns that are associated with peripheral catheter infections. And while we've seen increased awareness of peripheral catheter infections, there hasn't been a direct tie-in with ultrasound-guided PIV insertion specifically. And so when we think about these types of insertions, as you can see with this picture here, here's an ultrasound-guided peripheral insertion with gel all over the place and a naked probe. The probe is not covered in any way. The probe does not have a sterile cover or even an unsterile cover. Assuming that the probe was cleaned before and after the insertion procedure, that still may not be enough, as we know from some of the literature. So we see these types of inconsistencies, especially if clinicians can't find the right protection products, if they're not available. We know that touch contamination occurs during the procedure, especially prominent during the cleanup time, that after you've done the insertion and you're trying to wipe off all the gel and the other things, that contamination does occur because you're grabbing anything you can grab in order to wipe the gel off. And so these are areas and issues that we consider bad. We have good, we have bad, and we have ugly. We know with some of the surveys and research reports that variability is occurring. This is some research that I did in conjunction with Greg Gilbert, the statistician, that identified within more than 1,400 respondents that some of them were able to use sterile products and sterile covers and sterile gel, and some of them didn't. And actually the answers were always, sometimes, and never. And surprisingly, or maybe not surprisingly, many of the respondents said that they sometimes used sterile products, such as probe covers and sterile gel, and sometimes they didn't. We would assume that that may be based on variability for available products and things that you just can't find all the time. You may run out. There may not be replacement. especially during this COVID time, when more and more products were being used from cleaning and safety, there may have been a lack of product availability. And in fact, we have done a follow-up survey with some additional questions that did show us that sometimes supplies were not available and they couldn't be used. So not only did we see variability in the use, in the actual procedures and the use of supplies from department to department, but also from individual to individual, there was much variability. We saw also that 56% of vascular access specialists stated that they sometimes use different types of gel, sometimes used multi-use gel, sometimes use gel packets, and sometimes use sterile packets, that there was a lot of variability. And then we also saw that within the same group of vascular access specialists and emergency department clinicians, that there was problems with inadequate gel removal and sticking of the transparent dressings. So the whole point of this research was in order to confirm the hypothesis. It said that there was variability in the practice and in the use of supplies that could impact patient safety. Because of the variability, we need to look at ways to better apply guidelines and recommendations, the evidence that we have that's coming out more and more, helping us to standardize the procedure, helping us to reduce contamination during the procedure and really give the highest level of patient safety for ultrasound-guided PIV insertions. We know that various associations are looking at these issues and trying to come to some conclusions, some of which I'll present for you today. I'm not sure why there's sometimes delays with slide, but.
Here, let me advance the slide for you.
Thanks, Blake.
Not a problem.
It won't go. So based on Chowdhury and other researchers, as well as some work that I've done on the ESCAPE study, we know that there is a huge amount of bacteria on the skin, both on the surface of the skin as well as multiple layers deep in the hair follicles and the sweat glands and in other cracks and crevices that are present. 60% of our central line associated bloodstream infections are associated with skin flora. Most commonly, the coagulase negative staph. We have staph epidermidis as well as staph capitis. And then we have multiple other studies that are showing even more different bacterial species, both gram-negative and gram-positive. If the aseptic technique is not maintained, then we know that bacteria can colonize the insertion site, the insertion tract, and even go into the bloodstream. So what is the risk of contamination with peripheral catheters and ultrasound-guided PIVs? Here are some of the reports that have been done, and here is that ultrasound-guided peripheral IV, It's Time to Clean Up Our Act. This is where the 12 million times came from, as well as the original article from Gottlieb. And then we have an excellent review by Ruth Carrico and associates, and then the basic research on skin colonization by Chowdhury and associates out of the Avatar team. Focusing on ultrasound-guided peripheral access success is not the most important thing. And yet, that's really one of the things that inserters care about more. Am I going to be successful? Am I going to have to stick again? Are there issues that keep me from being successful? Failure to standardize the procedure is sometimes really just based on desire to get it in any way they can, get the catheter in. The supplies, what's available, if they're having to insert and attempt multiple times, they may run out of supplies. Certainly the areas can become contaminated and compromised. We know that bacteria comes from the skin, from the gel bottles that are multi-use, from touch contamination, as well as from the transducer probe and failure to disinfect it effectively. And so these are all areas where contamination can occur within the procedure. In the study that I had talked about previously with the survey of ultrasound-guided PIV practices, we saw that 33% of the respondents said that inserters at their facility used proper aseptic technique every time. Well, let's look at the flip side of that. That means that 66% or 67% said that they weren't sure or that aseptic technique was compromised. This can be an issue and certainly a problem. They really could only say that 1/3 of them said that they always followed aseptic technique and it wasn't compromised. We need to do something about this. We need to work on this more and make sure that this procedure is in fact safe as individuals as well as facilities. We've talked about contamination from the gel, from the skin, and from the probe. There's certainly lots of evidence of this in these various studies in the Society for Healthcare Epidemiology of America reports and multiple other Canadian reports that are listed here. Each of these types of gel are currently used. I have personally seen them in use in various facilities where they had not only multi-use bottles, but also ECG transmission gel because it was available and easy to grab. Lubrication jelly tubes that were multi-use, that were really designed for Foley catheters. We need to get a handle on using single-use sterile gel and make sure that the gel is not in and of itself a source of contamination. Now, even though I stress the use of sterile gel in order to avoid contamination, the associations, many of which do say it may not be necessary to use sterile gel for intact skin for our assessments for the procedure, as long as the gel does not come in contact with the area where the puncture will occur. So it depends upon what you're doing. We do need to not think globally as far as I will never use this, but to use good judgment in order to make decisions that are fiscally responsible as well as safe for patients. Inconsistent use of aseptic gel packets is very common. We've already addressed these issues and certainly need to recognize that when you look at procedures like this and images like this where the gel is spread out all over, that we limit the contact with the skin, that we make sure that we're using sterile gel for the procedure. In this particular image, you can see that there is a sterile drape being used and the process does appear to be sterile, such as with a PICC insertion or a midline catheter insertion. In fact, this is a peripheral-guided, peripherally inserted, a peripheral catheter that was inserted with ultrasound using a full sterile technique. It's questionable whether that's necessary every time, and it's questionable whether it's fiscally responsible. When we use gel, especially when there's gel spread out all over the space, such as we just saw, it's very difficult to remove that gel after the insertion procedure is complete. We know that the gel can contribute to contamination, and so it should be removed in an aseptic way. It may even need to be removed with an additional disinfecting process. That may require alcoholic chlorhexidine wipes to be available again, certainly sterile gauze, other types of cleanup aids in order to make sure that contamination does not occur after the procedure is performed. Gel left on the skin, inadequately removed, definitely contributes to poor adherence of the transparent dressing and the cover that's used with our catheters to protect them. You don't want to have to replace that transparent dressing. If it doesn't stick well, it certainly can lead to dislodgement of the catheter, and then you lose that catheter that you worked so hard to put in. It is additional cost to your facility for having to do it again. There are a number of ways that inadequate gel removal impacts our insertion, our procedure, and the safety of our patients. Transducers and probes can also carry bacteria. There has been a lot of discussion about low-level disinfection and high-level disinfection in association with ultrasound-guided PIV insertions. How clean is your probe? Have you adequately cleaned it before and after? Are there cracks and crevices on the probe that may carry bacteria and contribute to contamination of the insertion site? Of course, covers are necessary. Do they have to be sterile covers, or can they be clean covers? That many of these questions are still somewhat up in the air. We do need to recognize that our probes can contribute to contamination, as you can see from these different studies here. The CC has also addressed the area of disinfection for our types of visualization and ultrasound products and devices. There's more information at this website that you can see here, and specifically disinfection is recommended before and after the use of these types of devices. The American College of Emergency Physicians has multiple guidelines on cleaning and disinfection, as well as recommendations on guidelines for ultrasound-guided peripheral catheter insertions. Specifically, they say that cleaning should, that insertion should be followed by low-level disinfection in accordance with their guidelines. I do recommend that you constantly update your searches for guidelines, because there are many more documents coming out on a regular basis and more evidence that is helping to guide these decisions. The American Institute of Ultrasound and Medicine provided us with practice parameters for the use of ultrasound with vascular access procedures. They do recommend that each inserter have qualification and specific training for the use of ultrasound, that they understand how to use the equipment that they've been provided, as well as follow the evidence for applying safety within peripheral and central catheter insertion procedures. Adequate skin preparation is really key, just like hand hygiene and some of our other basic infection prevention principles. We do need to make sure that the skin preparation is done thoroughly. After we've done our first ultrasound assessment, selected the vein, measured our vein, make sure that we're prepared, good skin disinfection should be performed, and allow that skin asepsis to dry prior to performing the insertion. Clean or sterile gloves are acceptable by the AIUM. They also recommend having an adequate catheter length and performing the insertion transverse and then longitudinal. For ultrasound disinfection, as you're all aware, the Association for Vascular Access and Judy Thompson and others came up with the guidance document a couple of years ago. And then just recently, an intersocietal position statement was released by multiple organizations that went into some more detail on the type of disinfection that should be done. These organizations included the ACEP, the American College of Emergency Physicians, the American Institute of Ultrasound and Medicine, the Association for Professionals in Infection Control, APIC, and the Association for Vascular Access, as well as the Society for Healthcare Epidemiology of America. And in these disinfection practices in this statement, they specifically said that recommendations for high-level disinfection are not recommended at this time, because there's not an adequate amount of evidence that that guides this decision. So that process of low-level disinfection versus high-level disinfection is still in question based on a lack of evidence to guide a decision. They say that its use may result in unwarranted and unnecessary use of resources. Certainly, high-level disinfection does have an increased cost, an increase in the types of supplies and other things that are used, as well as a time cost to clinicians, limiting the number of ultrasound-guided peripheral insertions that can be performed. They specifically state within this document that the ultrasound transducer or probe need not be sterilized, that providing a cover for that probe is adequate for the procedure. They do focus on making sure that the ultrasound gel is bacteriostatic or sterile and not contaminating the procedure. So I refer you to that document for more information. I hope that it'll be available on the AVA website soon, but you can also Google it and find that document. AVA, as well as the Infusion Nurses Society, have supported the use of the aseptic non-touch technique for certain procedures. The aseptic non-touch technique is certainly applicable to ultrasound-guided peripheral catheter insertions, as well as any peripheral catheter insertion. If we utilize this technique well and follow the training and instructions within the ANTT approach that is outlined within this guidance document, as well as within the INS standards of practice, I do believe that we can improve practices and reduce the risk to our patients during these procedures. For transducer and probe protection, there are a variety of options that are available, some of which you can see here. This is the good. It's nice that we have other types of products that are available, either sterile transducer covers, as you can see, gel separating dressings that may allow you to keep the gel completely away from the insertion site, and then the gel pads that are also available to cover the transducer or apply to the skin. And so there are a variety of options that, after our transducer is disinfected before and after use, we can use these types of methods in order to protect the insertion site. You can see here, the bad is using unsterile gloves to cover and kind of make it difficult to hold it, make it difficult to visualize well. Of course, you'll have to put gel inside the glove and then on the outside, and you don't have a very flat surface to work with. I consider that bad. Even ugly. It can result in ugly when you smear the gel all over the place and just can't get a good aseptic procedure going. There are scanning pads that are now available. Imagine that you can put a hydrogel type pad on the skin and assess through it in order to find a good vein. The pads also can be applied to the transducer, similar to the way that we apply the transparent dressings. And they seem to be acceptable by the manufacturers in terms of the adhesives. But we also have the transparent dressings that are applied over the transducer probes. And I have concerns with those. Number one, in how they're applied. Number two, in whether there are holes or pores, because we know these transparent dressings are semi-porous, that they allow breathability, that they may allow tears or other things to occur. And so transparent dressings, at least by some organizations, are not recommended. We do want to protect our our probes, our transducers. We want to make sure that they're effectively disinfected prior to use. No one wants to go and grab an ultrasound that someone else has not cleaned up and there's blood on it, or there's other things, or even just that we're concerned that it wasn't cleaned adequately. And so we want to make sure that we clean before and after, being responsible for the next person who's going to use it, making sure that the equipment, especially the whole ultrasound device, if it's taken into an isolation room, is cleaned effectively. One organization out of Australia specifically states, the World Federation states, that we should clean the transducer or probe first and then disinfect it. So wipe it off well, maybe even clean it with soap and water, and then disinfect and allow it to dry. The gel-free insertions with the probe protection and can also utilize single-use gel and not sterile gel. If the gel doesn't come in contact with the insertion site or the puncture area, then you may be able to use the less expensive single-use or bacteriostatic gel. But still, the associations are recommending that we use single-use gel, or if you are using the multi-use gel bottles, make sure that they are capped or covered after each use and potentially even wiped down in order with the low-level disinfection in order to prevent contamination of the multi-site, the multi-bottle. This was an article that was published by Thorne and Associates on performing an insertion procedure without gel at the puncture site. And I can show you the next picture here is how they used a transparent dressing in order to separate the gel from the puncture site and still visualize through that transparent dressing. This was a publication in 2016, and at least one of the products was developed as a result of this original publication to try and separate gel from the insertion site. The recommendations of using a single packet or single packet sterile or a gel-free solution for the insertions come from our different associations. Yes, as I said, you can use water, saline, other things, and again, these should be sterile. I have seen people use a flush from a syringe that is a sterile solution, but it just doesn't visualize as well or as long. So you have to decide. We do need policies and standardization for these procedures. I don't know if it's happened to you, but I've seen people watch me do an ultrasound-guided peripheral insertion and say, oh, that looks easy. And as soon as you turn your back, they go off and try it themselves. Yes, we can make it look easy, but training is really necessary. And in my mind, I have a bit of a soapbox that I believe that we should monitor all inserters and make sure that they maintain an 80% or greater success level. I think that that should be a benchmark for all of our inserters, and that if we monitor those levels, then we're able to identify those people who need additional training, additional simulation work, that we're able to identify people who may not be as safe as for patients as we need them to be. By the same token, we should also monitor their compliance with the policy and insertion procedure and supplies that the facility has decided upon. And that doesn't seem to be done very well. I know very few facilities that have any kind of policies or intervention after the initial training. And so I challenge all of you to look to additional monitoring in order to make sure that we're in compliance, that everyone has adequate competencies in the procedure, and that we do promote standardization, not only among the vascular access team, but from department to department, because so many different people are performing these procedures. So when we think about ultrasound-guided PIV insertions as a multidisciplinary process, one that incorporates physicians and nurses and the emergency department and the ICU and various departments throughout the hospital, as well as a vascular access team, we really need to emphasize multiple elements. We need to make sure that they are performing aseptic technique with a proper procedure, with ANTT or whatever procedure your facility has required, that they use adequate probe protection, both for disinfection and for covering the probe during the procedure, or at least separating the probe by some method. That they're using a single packet gel, whether it's unsterile or sterile, bacteriostatic, that it is single use, and avoiding the use of multi-use bottles or packets or tubes, and without special controls that you have applied to those multi-use containers. And then, of course, making sure that we consistently have adequate levels of probe disinfection. And so when we think about, the safety challenges that are presenting us in the use of ultrasound-guided insertions with all these disciplines and departments, we do have a professional responsibility to work towards a higher level of patient safety and minimize the risk to the patients. And we need to look to standards and research, even potentially government regulation that helps us to apply best practices. The standardization of this procedure, I think, is very important. We need more evidence that helps us to have some definitive decisions on the types of products and things to use. But in the end, it comes down to consistent education and compliance monitoring. We need to make sure that when a policy is established, that everybody's following it, and that competency measure is done more than just once, that it's something that may need to be repeated in order to ensure that everyone is still following the same procedure and having the same level of success for our patients. We know that specialized teams, we have a fair amount of evidence now that's growing that shows that teams are more successful with these insertions, that teams have a better grasp of ultrasound for vascular access insertions. But, teams within the emergency department, teams within the entire hospital, especially trained people within the ICU, it may come to the point that everyone knows ultrasound and can do this procedure effectively, but as long as we're all following the best practices, the guidelines that are established, we can ensure that level of safety and success for our patients. Facilities should assess their existing ultrasound and the users, those that are actually performing procedures, especially for ultrasounds that are being used for multiple different types of procedures. I know in my discussions with Ruth Carrico and others, that was one of the greatest concerns, that there's less concern for an ultrasound that's used for vascular access over and over, as opposed to one that's used in an intensive care area for multiple different types of procedures that may be more or less invasive, and the same level of disinfection or attention to asepsis is not performed. And so we have to think about all these things. There are a lot of issues that I've presented today, a good bit of evidence. I do have references that I can send to you, as well as I know that they plan to share these slides with you, as well as the recording. So now we can look at some of the questions.
Absolutely. Nancy, thank you so much. And we will get to the Q&A. I do want to let everybody know at this point that the CE portion of the program is over. And during the Q&A, we can be talking about products or names specifically. So thank you so much. If you guys have questions, as Blake said before, if you could put them in the Q&A area, that would be great. If you'd like to ask Nancy your question on just by opening up your mic, we're happy to do that for you. But we will get to the questions right now.
Well,
is a transparent dressing okay if sterile gel is applied to the probe first?
That definitely would protect the probe face better. You also may get better visualization that way. It's ooey gooey, and I hate cleaning up the probe afterwards, but yes, I do believe that that's a better way to do it rather than applying the transparent dressing directly to the probe face and having that adhesive problem.
Thank you. Blake, do we have anybody that wants to come on camera or
I was
open
just
their
going
mic?
to ask if you guys wanted to raise your hand, if you want to ask a question. I would love to hear you guys on the mic.
I'm going to answer a couple of questions. One, how do we access the recording? In AVA Academy, it'll be there in about 10 days, plus or minus, and you can go there and there's no charge to watch it. There is a charge after the live event for the CE. So if you just want to come and check out the talk, come on over. It'll be there in about 10 days. And the slides are available. And Blake, you want to let them know how to get them?
Yeah. So once I've compressed the file and made some tweaks, so tomorrow you can go to avainfo.org. Let me get that right. avainfo.org. And it's your slash is going to be Ava webinar handouts. And you'll be able to go back and look at any of the old slides if you happen to be on a previous webinar. Again, it's all based for this file size, so I'm still working out a solution because these have awesome images and are so.
Very
Got
good.
some really good questions.
Yeah,
We do.
So one of the ones by Chris was talking about how do we monitor staff? Now that we have so much electronic medical record and within all of our hospitals, we should be able to set up fields and ability to monitor number of attempts. Recognizing that people are not always honest, this may not be a complete way to do it, but you can also monitor for complications. I do think that we should have some level of reporting by inserters, possibly another means of registering it through a SurveyMonkey tool that can be set up where they can do it through their phone. Another way to just keep accountability with all the inserters. And a kind of a follow-up to that, you know, if 100% of the staff are doing ultrasound-guided insertions, that makes it really tough. But if they're going to take on this added skill and recognize themselves as a specialist with ultrasound, then they need to be accountable and to be able to help to find a way to do reporting and to keep track of complications as well as success levels. I'm not saying it's easy. I'm saying that we need to really investigate ways in order to monitor for compliance as well as success levels in order to provide more education and training when it's needed. One of the other ones by Lorraine Lenford. Hi, Lorraine. How can you keep the site sterile if you're using a sterile probe cover and clean gloves? Aseptic non-touch technique. You know, the issue of sterile gloves versus non-sterile gloves, anytime you touch the skin, your sterile gloves are not sterile anymore. Even though we've cleaned the skin, it's not sterilized. The skin is going to put bacteria on your gloves. So the goal really is to minimize your skin contact, focus on those sterile parts, which are the needle itself. Keep one hand as sterile as possible, and you can use the other hand on the probe. Although if you have a sterile probe cover and you're using clean gloves, it's not sterile any longer, which is really why I think the AIUM never really said that probe covers need to be sterile. In that intersocietal position statement, I was actually surprised to note, we were talking a little bit about this before the webinar started, never once did they say that the probe cover needs to be sterile. I find that interesting, and it is true that we don't have enough evidence to say exactly what we need to do. So, you know, these are some of the questions that are still not completely answered. So Lorraine, you've asked a really good question, and I think aseptic non-touch technique is really the way to go, that we teach people what to touch, what not to touch, and how to do the procedure in a safer way.
Just to add a little bit to that, on that intersocietal paper, because I was involved in it.
Yeah, thank you.
I know you did your best not to throw me at that bus, but I'm
know.
proud of the paper. I think it's a great paper,
Yeah.
and the purpose was talking about disinfection, not about the procedure. I'll start there. But
Yes.
the entire skinny on it, the lead from that paper, which is Dr. Kripken's, and myself will be actually presenting at AVA this year on that.
Nice.
So,
Excellent.
and it won't be the last session of the day of the conference this time. So just FYI, there's more to come on that.
Well, I have to compliment Ava on coming out early with disinfection guidelines and the position statement. And while there were other associations that kind of did it, I really think Ava did a good job of reviewing the issues.
Thank you. I appreciate that. Chad's asking about his membership hasn't been expired right now. Is there any other way to get the slides? There's a couple. You don't have to be a member to go and get the slides, though we'd love you to be, but it does not require you to be a member to get them, nor are you required to be a member to go to AVA Academy and watch this again.
Yeah, if you go to that link that I put in the chat, you can access it. It does not require membership to do that. So
At this time.
If you're listening,
yeah. So Megan's saying, thoughts on high-level disinfection for every exam to be proactive rather than reactive.
Yeah, my feeling on the disinfection intersocietal position statement was that there wasn't enough evidence to support the use of high-level disinfection for every one of our vascular access procedures. That this is a pretty expensive process. Judy?
Yep. So
I'm sure you have some things to say on this.
I do. So I think one of the points that we made in that paper, and this was Dr. Kripken's again, he said, we clean our hands with soap and water, and then we put on sterile gloves. And surgeons put those gloves into patients' bodies. Then I'm not trying to equate our vascular access procedures with that, but we are having with a sterile cover on our probe, and then cleaning it's overkill at this point for what we're doing. And like Nancy said, we don't have the evidence to say high-level disinfection all the way. Now, in reality, everybody uses an intermediate level disinfection. I would challenge you to find a low-level disinfection that you use in a patient care area in your hospital. I worked really hard to try to get the paper to say intermediate level, and that we had a couple of physicians that scoffed on that. I lost that battle, but I stand by that paper. I think it's a great piece of work. So,
well, our disinfecting products and stuff, I think, have continued to improve over time, especially with the impact of COVID. And so it may be that we have better and better disinfecting wipes and spray solutions and other things to use. But as long as we're covering our probes, or at least separating the probe from the insertion site, then our patients are protected.
Absolutely.
Nancy, you mentioned that the sterile field gloves or sterile insertion might not be fiscally responsible. Can you explain a little bit more about that?
Yes, so what I was really leading to was a full sterile procedure. The use of, complete sterile kits. I don't want to knock anybody, but, the cost is associated with all sterile products for peripheral insertion may be prohibitive for hospitals. It may not be fiscally responsible, not just in terms of sterile gloves. I really intended to apply that to a full sterile procedure. Peripheral catheter insertions have historically been a clean technique. While we maintain sterility of the items that we're using, such as the needle on the catheter and the connection points that are all consistent with the aseptic non-touch technique, we have not applied a sterile drape, sterile gloves, or other things. Some of our IV start kits do have sterile gloves, but if you're going to get a sterile glove packet and a full sterile procedure to do a peripheral catheter insertion, I do think that you should consider the cost and consider whether you have enough evidence to support that cost in protecting your patients. Sometimes, this is my opinion, I do think that we go too far when there's not enough evidence to support that action. And so crucify me if you want. These are just my opinions, but I do a lot of reading and a fair amount of research. So I try and provide you with good information.
Do you think that that's going to change with the ECRI patient harm statement making it the top one on the top 10 list?
I think just like the central line bundle, that we need to be aware of the foundational aspects, the hand hygiene, the skin disinfection, the awareness of making sure that our probe is protected and we're using gel that's not going to contaminate our insertion site. Then we do the cleanup. We're using supplies that are not already contaminated. I mean, how often do people reach over and grab the gauze that they've already used for something else? Or they use it multiple times? I mean, I've seen it. And so, or you use the alcoholic chlorhexidine swab that you've already used on the skin. That's not good. We need to take and give attention to these foundational aspects. And if we're truly doing good ANTT, I do believe that we're providing a higher level of safety for our patients. Yes, you can use sterile gloves if you want. If you feel like that is a better way to safeguard this procedure, especially with many different inserters, I don't have a problem with that. I'm not saying don't. I'm just saying be aware of your actions, be aware of your supplies, and be aware of the cost that's associated with these things, that some of them aren't necessary. And you put on sterile gloves, I want you to be aware of how quickly you contaminate them.
Does any of this change your answer if you're putting in a midline?
Yes. So we know that the standards of practice say that midline catheters need to be inserted with sterile technique. That, while we don't use maximum barrier precautions with midline catheters, we do use a sterile procedure. The midline is technically designed to stay in longer than a peripheral catheter. And while they are both peripheral catheters, and while I recognize that the term midline and extended dwell and deep access and all these different names are associated with it, and that you could cross over and say, well, it's kind of all one and the same, maybe we should do sterile procedures. The good, the bad, and the ugly, this all gets kind of mixed in. And we're still trying to define our nomenclature for these types of devices. A midline catheter that's longer, a longer catheter needs to be performed with a sterile insertion procedure. Short peripheral catheters, or long peripheral catheters, as we're calling them with ultrasound guidance, may not need to have the same level of sterility. But again, as I've said throughout this entire presentation, you and your facility need to decide on what your policy is. Based on all of these associations and this evidence, make a decision based on these things. As a speaker, I don't ever want you to believe what I'm saying and to take what I say as gospel. I think that you should always validate the information, that you should do the reading for yourself, and make sure that you are in agreement with the evidence that's there as you develop your policy.
Absolutely. So Blake, somebody said that the AVA info handout link does not work. And back to Nancy on that. What are your thoughts about using CHG or ChloraPrep sponge as a medium and antiseptic for ultrasound use?
I know that you can use alcoholic chlorhexidine on your probe in order to visualize. As I mentioned earlier, the alcohol can cause cracking with this most expensive item in your ultrasound. I think they're really asking if alcoholic chlorhexidine can be used to clean the transducer before and after. I'm
No,
not quite
I
sure.
think it's in lieu of gel. In fact, I've run out of gel and used it before.
Yeah, like I said earlier, we can use any kind of fluid in order to remove that air and allow visualization. It may not last long, and you may get kind of spotty visualization because the skin absorbs it very quickly. It dries out fast, which alcoholic chlorhexidine is supposed to dry quickly. But yes, it can be used. I've seen insertions using it. I prefer to use gel because I know I get better visualization. I think it's preference, but there's also a concern with the alcohol on the probe itself.
Perfect. Ultrasound-guided PIVs often stay or last as long as some midlines. What's
It's
the
true.
rationale? It is true. What is the rationale for aseptic technique for ultrasound-guided PIVs versus sterile technique with midlines?
Well, let me flip the table. We perform PICC line insertions and central line insertions with maximum sterile barriers. The amount of evidence that supports that is actually somewhat minimal. What is the evidence that supports a sterile insertion of a midline?
It's yeah.
There's not a lot. And so, you know, you're asking me to justify why ultrasound-guided PIVs are not a full sterile procedure when I'm saying that midlines are, and I specifically said because INS standards say so. We have concerns over peripheral catheter infections. I recognize that that risk alone tries to drive us in order to using better practices. Have we addressed all those foundational principles such as good skin, antisepsis, making sure that we're not touching the skin as much as possible, that we are doing a non-touch technique? If we can do all that, like our counterparts in Europe and in the UK, then I do believe that we can have a very low infection rate without going to all the sterile supplies and the cost that's associated with it. But I could be wrong.
Just want to let everyone know that I just checked the link. I just posted it again in the chat. It does work. And if you guys are having any issues with that, don't hesitate to reach out to how about the email? avaed@avainfo.org.
Okay, let's go through a couple more questions here. I think, how do you place a sterile cover on a probe without using sterile gloves?
You don't.
There you go.
And so really that kind of underscores that intersocietal statement about using probe covers and not designating them sterile, because I believe that as soon as you put the cover on, even if you're using sterile gloves, you're very likely to contaminate both the gloves and the probe very quickly into the procedure. So, you know, how rational is that? I think we need to work on our steps of the procedure and make sure that we're doing it in the best way possible. You know, many of these questions are tough questions, and I probably should not have answered them quite as strongly, but you got my full opinion, and I'm very honest.
I appreciate that. And the paper was written for central line insertion as well, more so as a big focus. So, which we are going to use a sterile probe cover. But Dr. Ryder has a great question. I think she's just backing up your point here. What's the difference in the pathophysiology of catheter-related bloodstream infection between PIV midline and a central catheter? It's all the same blood.
Yeah, it's all a bloodstream infection. Good point. Very good point. So do we need to insert, you know, all devices using sterile technique?
If it was my loved one, I'd want it. Or I'd want a vascular access specialist doing it that I respected. So I think
So
this is,
when we think about the vast number of peripheral catheters that are inserted each year and the incidence of infections that has been reported in the past, we've got to be doing something right. I mean, while we want to eliminate infections, there's more bacteria in the world than people. And we can't eliminate bacteria completely, especially from the skin. So I don't know. I think we need to be rational about the process and make sure that we apply the evidence well, the evidence that's available.
I do. I agree with you, but an infection, it doesn't matter what the numbers really say. If you have a catheter-related infection on yourself or your loved one, that's a N of one, but that one is really important.
Agreed.
So Catherine Taylor has a something we all talk about.
Good
We don't
point.
provide enough education, and new products don't fix issues. So I think that's a problem every hospital has.
So can I address a couple of other things? There were a couple questions on adherent probe covers. Thank you to Civco for sponsoring this presentation. We did not include information about product specific, but now we're in the question and answer. So somebody asked about adherent probe covers. Civco has a hydrogel, a pad that can be applied to the probe, and it can be applied to the skin. The other question is there more information about the gel-free probe covers and pads? So Parker Laboratories also makes what's called the Ultra Drape, which is a dressing, like a transparent dressing, that separates the gel from the insertion site. Both the Civco and the Parker products can eliminate the gel from the insertion site, so that you don't even have to worry about that as a contaminant, and you don't have to worry about that in removing it and cleaning up the process.
Thank you.
Bunch of other questions. You guys have my email, nancy@picexcellence.com. I'm happy to address these questions if we didn't get to them. Sorry.
Well, Nancy, this was wonderful. Thank you so much for your information and your presentation. And everybody that's still on, thank you so much for hanging in. And I'd like to echo what Nancy said. Thank you, Civco, for sponsoring the program today. And we'll see you next time. Thanks, everybody. Be safe out there.